versus 87% for tile breathing with no O2. He said, so for eyelid and orbital surgery where it would not be possible for the patient to wear a mask, I don't think the risk differs much more than tile breathing with or without low flow oxygen. So if they're pre-screened and they're COVID negative, the risk is low but not zero. So even though it's probably widespread in the community and the surgeon has their face within a few inches of the patient's face for about an hour, in his opinion, he thinks it's reasonable for a surgeon to wear an N95 and eye protection. So, we talked about putting, a damp gauze over somebody's face or that sort of thing. But it's not practical. You can't sterilize a mask. One of the reasons I leave the whole face open for all my cases is so you don't get oxygen, tenting underneath the drapes, which becomes a fire hazard, in any situation. So we may end up with, I think for our MAC cases, we just may end up with the patient without anything, or put a gauze over their face, over their mouth if they tolerate it. But I think with an N95 and eye protection, our ID seems to think that that's probably reasonably safe.
Yeah, okay. One more question says, a few retained sense of smell indicate a poor seal. Yes, it does. And it is a good metric. That's basically what fit testing is. You shouldn't be able to smell anything through that mask unless it's your own breath. But right. But yeah, that I would get. So you're not supposed to be able to smell smoke. If you smell that through the N95, that means you don't have a good seal.
And I also will note that there are a lot of companies out there on the internet that are trying to peddle their quote KN95 masks and other PPE. A lot of the knockoff stuff that's coming and being made very poorly, you can actually check how good it is by putting it on and seeing if you can smell things like alcohol or a spice or whatever you have near you. If you can smell something through it, then it's probably made poorly. You can also pour water inside the mask. If the water leaks through, it's a poorly made mask. It's not really a KN95. So there's a lot of counterfeit stuff coming out as people are trying to profit off this situation. So just buyer beware.
And there's one other thing you're supposed to do every time you put the N95 on, is when it's on, you put your hands over it and you inhale and exhale, and you shouldn't feel any air coming out the sides, and you should feel the material move a little bit when you inhale and exhale.
Yep.
That's every time you put it on.
And if you also think, that's actually a third test you can do for a fake N95 or KN95 mask, is you could put a candle or a match or something in, like a little flame in front of you and try to blow it out. You should not be able to make that flame flicker at all. So if it's flickering, you are not wearing an N95 or KN95. You've been sold something that's a little more shabby.
Yeah. And then the other question is, do you believe we compromise our precision with PAPR? I tried that out with the loops and the headlight. The idea of the PAPR is you actually almost like with the one I was wearing, that capper, I felt like I was wearing nothing. I don't think that would compromise precision at all. Though I can't wear the regular OR light, which would have been brighter. One thought was that I could have an assistant, if in the deep orbital surgery, you can have an assistant hold an endoscopic light, and that could aid in lighting the field if the little light on your loops isn't bright enough.
Scott, you want to go?
Right. Here's a good question. Is anyone using room air distributions, disinfections, recirculators like those total joint cases? I don't think, maybe in a hospital that has those, or an ASC that has that available. Actually, one study over lack of time in Singapore. Okay, in Singapore, they actually
everybody mute, please.
These hyper H2O2 it just kind of distributed a mist of H2O2 all over the room, and it would kind of purify and clean. And so I don't know that we all have that available, but that is a good question to ask your surgery center if that's available. That would be, I think that would be ideal to do in between the aerosolizing cases. Scott, why don't you present your...
I'll jump in at this point. So, I think the PPE commentary is very, very important. And what I'm going to just sort of talk about are in broad brushstrokes, what do we know? What's out there in terms of guidance and guidelines in this new era? And again, I have no financial interest, and as was noted from Dr. Miglioria, this is not an ACE operator sanctioned event, but even though I'm the treasurer, I'm not speaking on behalf of the society. So again, we know that COVID is rapidly ushered in a new era in medicine that we haven't really experienced in our lifetime. It's been decades. You can go back to the HIV crisis that came out in the early 80s, or you have to go back to other sort of, polio in the 1950s or the Spanish flu in 1918 to sort of hit major public health crises that we're experiencing today. The key thing is that the guidance and guidelines have rapidly evolved over the past 2 months. And the only thing for certain is that they will continue to change. Stu and Mark Mazo can, attest to the fact how many times the PPP criteria have changed via the CARE Acts and how many times all those new laws coming out of Congress have evolved. And at this point, it's more confusing for us when we're talking about opening our offices and getting back to work because the federal, state, and local guidelines vary widely as the infection prevalence varies widely. And here's just from the Johns Hopkins University Coronavirus Resource Center. There's a great resource center. You can pull up a U.S. map and it'll show you where all the hot spots are. And you can see very quickly that the Northeast corridor along the I-95 corridor from Washington, D.C. to Philly to New York to Boston, heavily impacted. You can see areas down in rural Georgia near the Mississippi border, around New Orleans in Louisiana, the New Mexico-Arizona border, up and around Denver, state of Washington. There are definitely some hot spots out there. And this is updated on a regular basis, but it gives you a nice idea that, if you're practicing here in Philadelphia or towards New York, your level of precautions and concerns and risk for getting exposed are probably much higher than if you're hanging out here in northern Montana. So be aware that these policies are taken with a grain of salt and you're going to see different things in different areas. So it's very hard for the federal government to issue blanket statements that can be applied to the entire country because the prevalence is so varied throughout the country. Nonetheless, the White House did come up with its Opening America plan a few weeks ago, and they point on their criteria, their preparedness and phase guideline approach. If we look at this one by one, the criteria is really data-driven, looking for downward trends in symptoms and cases at the local and regional level. So we want to try to get a sense of, is the infection rates still rising? Have they peaked? Have they plateaued? Or hopefully they're starting to decline. And most people are recommending at least a steady 14-day decline in new cases before you really start getting back to work. In terms of preparedness, the federal government has pushed a lot of the efforts back to the state level to their own frustration because they feel like they could use more federal support. But nonetheless, state level testing and state level coordination of contact tracing, hospital planning, emergency planning, and even down to the level of the county and township level sometimes in certain places, depending on the population density of where you live. So everybody has to sort of stay attuned to what's going on in their part of the world where they live. In terms of phase guidelines, the White House came out with guidelines that are based on current data, trying to mitigate recurrence of these infections, and trying to protect the safety and welfare of everybody that lives in this country. So phase one is continue to shelter in place for everybody, keep your social distancing, and protect yourself. But they did say if there's been a steady 14-day decline in cases, it's okay to start elective surgery. At the same time, all bars and restaurants must be closed for patrons. When you hit phase two, if you prove that there really has been no rebound in cases as you've opened up, you can start to loosen restrictions, and healthy people with no underlying medical issues or younger people can start to travel more freely, whereas people who have underlying immunocompromised medical conditions, elderly, should still probably shelter in place. And finally, if you can get through a short period where there is no rebound and people are doing well, then you can get back to phase three, which is a total complete return to normal life with no restrictions. So here's an interesting daily incidence map that was placed on the Department of Health website here in Pennsylvania. And you can see that Pennsylvania was broken down into 6 regions. The purple line is the southeast corner of the state where Philadelphia and the 5 counties around Philadelphia are located. You can see that's where the vast majority of these cases have been. And if you look at the north central, the northeast, so the north central and the northwest and the south central parts of the state, the lines are very flat. There have been very few cases in other parts of Pennsylvania. And, just like you saw in rural parts of Michigan, people coming to Lansing yesterday, you're seeing uproars in certain parts of the country where the infection rates have been minimal, and they're frustrated with the economic impact. So your decision-making is going to have to vary based on where you practice in the country. Here in Philadelphia area, we're being told that things are going to start to gradually open up on May 18th. The American Society of Anesthesiologists has a slew of useful resources on their site. And if you just go to the www.asahq.org, you can start finding under their news columns all these sort of interesting joint statements and statements they put out. And I'm going to highlight two that were put up. The one from April 17th was just updated yesterday, and the perioperative testing for COVID was put out 2 days ago. So in a roadmap to resuming surgery, facility readiness is required to resume elective surgery, and it's going to vary by region based on infection rates of new cases. So you have to sort of look for that time of reopening based on a sustained decrease in new cases over a 14-day period and following local and state health departments. COVID testing is encouraged but not mandated, as there's a high level of variability of infection rates around the country, as we pointed out, and there's a lack of consistent results with the testing and a lack of availability of the testing. So for that reason, you're not going to see a CDC recommendation saying you have to do testing on everybody. Nonetheless, CMS and most major medical organizations are highly recommending that you do that. PPP, as we just covered, is essential. As Sandy pointed out, head and neck cases have the highest risk for spreading, and our ENT, dentistry, and ophthalmology colleagues are really at the highest level of getting infected. As we get back to doing surgery, we're going to have to start prioritizing our cases. So you're probably not going to be doing a long facelift with fat transfer and a four-lid blast to start off as your first case back. The University of Chicago came out with something called the MENTS score, and I'm going to come back to that in a second. And priorities are going to vary based on the region and based on the facility that you're working at. Like Holly, I happen to own my own practice in the suburbs with my own ASC. I'm also on staff at 3 local community hospitals where I will cover cases, and I'm also on teaching faculty at Wills and at Penn. So from place to place, the restrictions and guidelines have varied bit to bit just here in Philadelphia, let alone the rest of the country. Perioperative workflow planning, extremely important. I had 2 meetings this week for probably a total of 4 hours working with my OR staff of how are we going to bring patients into the OR, get them registered into the waiting area, to the operating room, back out safely so that we can minimize their flow in the office. We're going to do a one-way flow from the front door to our back door. We're going to cut our room use down in half. We're going to cut our schedule down to 25% normal for the first few weeks until we can establish that our flow is working properly. And then you need to follow data and continue to do risk mitigation. If you're not looking for problems, you're not going to find problems. You got to be vigilant, see how your patients are doing and what's happening with your staff. Because key here is this is probably going to be a long haul, not a short process. There was an article that I read today that said that we could be in for a 2-year course of recurring infections or sort of lingering infections. So for the short term, medium term, and even potentially the long term, the way we do business has changed. Now, Holly did bring up the point of, do we do testing on everybody? Well, again, it's not mandated by law or the CDC or by CMS, but it is typically recommended that you try to do testing 2 to 3 days in advance to get a sense, is the patient positive? This is much easier to do at a university or a major hospital where they have testing available than it is at a freestanding independent ASC like I operate out of most of the time. If these tests are done more than 7 days ago, you need to repeat it. The rapid PCR test is the fastest and most easily available test to get. Antigen testing is also available, but some of these can take several days to get a result back. So if you're trying to get something within 2 days of surgery, you want to probably lean towards the rapid PCR testing. Antibody testing is questionable. A lot of the tests that have been released in the United States came out of China. They did not go through FDA approval, and they have not been validated. So they may very well be unreliable. Also, nobody really understands what is the time course it takes for IgM levels to peak and wane, or for the same token, how long does it take for an IgG to sort of come up and stay positive? In addition, in South Korea, there have been case reports of patients who were known to be COVID positive back out in society and got infected a second time, and on repeat testing, were carrying the virus, but were asymptomatic. So antibody testing may help let you know personally your risk of getting a significant infection, but it's not really a reliable way to test our patients. So bottom line is testing is not universally available or easily to obtain. You check with your local hospitals, your university hospitals, but the availability has been somewhat inconsistent and changing rapidly despite what you're hearing coming out of the White House. In some states, tests are available at outpatient labs. In some states, you can go to outpatient pharmacies. Rite Aid has testing, I believe, in about 7 states. CVS has it in about 5 states. Walgreens is now starting to ramp it up in some of their states. So you got to look around and find out where you can get your patients tested. The MENT score is sort of a risk stratification score that can range from 21 to 105. And you can see it's broken down into 3 blocks. One is the OR time, how long you're going to be in the OR, estimated blood loss, how many people are going to be there, you're likely to be intubating the patient, is the surgical site near the head and neck. And based on these, you can give yourself points. And I sort of put in what I thought would be a typical oculoplastic patient. You can see this upper box, they scored about 13 points. Most of our patients don't have significant issues, so be it ptosis and blephs and ectropions, chronic tearing. If we delay surgery 6 weeks, the disease is going to be minimally worse, and the effect on their health is going to be minimally worse. So we're going to kick up our MENT score in this section. And then finally, looking at the overall health of your patient. Patients who have lung disease, higher risk if they get infected. People who have obstructive sleep apnea, increased risk. Diabetes, cardiovascular disease like hypertension or congestive heart failure, all increase your risk. So ultimately, the higher the score, the more risk. And especially at university hospitals, when they start opening up the ORs, you're going to find that people who have an infected hip joint or have appendicitis or chronic cholecystitis may and probably will get prioritized over, say, cataracts or an ectropion based on these scores. So be aware of these scores. In the ophthalmology only setting, the score is going to be more similar, so it's going to be harder to utilize this in an ophthalmology only setting. But just be aware that this score does exist. And then finally, other factors in reopening surgery centers and offices, making sure you have adequate protective gear, gowns, gloves, masks, face shields. We just covered very nicely. Workforce availability is probably going to be the hardest thing right now because of the unemployment benefits and the $600 additional payment on top of normal unemployment. I can tell you in my office, my staff does not want to come back more than half time because they're going to lose $600 and they're making more money sitting at home than they can make working. And I'm hearing this all over the country. And if we don't have enough workforce, we're not going to be able to get the work done. So where we were putting a plan in place for a few weeks out to open up our office, we couldn't get enough staff because nobody wanted to come back. They're happy being on unemployment. So be aware that that can be an issue. In terms of facility considerations, in my office and my operating ASC, we have removed the bulk of the chairs in the waiting room. We're not really letting people wait there anymore. We're making people wait in their cars, which is going to become more of an issue, especially as you head into the South during the summer when it's 100 degrees outside. But we're trying to minimize visitors in the office. Come in by yourself unless it's a pediatric patient. They can come with one person, or if it's a disabled person or somebody who doesn't speak English and they need a translator. But we're trying to minimize waits and minimize the number of people coming through a facility. Sanitation protocols are very important in terms of terminal cleaning for the operating room between cases and surgical areas, and even each office and piece of equipment that you use. Be aware that you got to be looking after your supply chain management. This is true for both the office side and the ASC side. An important term you may need to get familiar with is allocation. A lot of these larger companies are allocating their resources and divvying things up rather than in one place order everything so that everybody can get a little bit. So you have to ask, what is my allocation for gloves or masks, and how soon can I order again? So they may offer you 2 boxes and you can order again in 14 days. So your staff has to be very on top of your current inventory, making sure that you're ordering appropriately. And then finally, in terms of testing and screening your staff, yes, temperature screening, not super helpful. Asking people if they have symptoms, not super helpful, but doing something is better than doing nothing. And you can certainly get antibody testing somewhere down the road. We may start seeing that, but even the World Health Organization is not recommending antibody testing in a broad fashion. So keep in mind, the vast majority of patients around the world who are spreading this infection are typically asymptomatic or are spreading the virus 2 to 3 days before they become symptomatic. So the presumption is that everybody has this infection until proven otherwise. And you got to protect yourself. You know, the resources that I can recommend, you may want to just snap a screenshot, but you know, Johns Hopkins University has a great resource that you can sign up for daily emails on the coronavirus. The American Academy of Ophthalmology has done a fantastic job of putting out e-blasts almost every day. You can pull up a lot of recommendations on our website. ACE-Oppers, we are updating on the COVID page for members, so you can log into the ACE-Oppers webpage. That's been updated regularly. And a lot of these papers and sites that I've cited in this talk right now are actually listed on the ACE-Oppers resource page. And then you can see there are other resources out there. So with that, I will say thank you and stop sharing my screen and head back to this view.
All right, thanks. Wade? You with us, Wade?
I'm here for now.
Here we go. Why don't you go ahead?
Okay. Let me get my screen up. Can you see it?
Nope.
Hmm.
Well, while we're waiting for Wade to pull up his slides, maybe we could discuss some of the questions on the chat. One was the a question of do we do DCR? Yeah, and I think it sounds like most people would require an N95 to do the DCR. We're basically going to try to just do all procedures with N95. All of our staff, even in clinic, are issued N95s for 1 per week. So we have to do the extended wear. There's studies that show extended wear, meaning wearing 8 hours straight, is safe and appropriate, especially if you protect it. And if you protect it with another mask on top, then you could reuse that as well. Some people have talked about sterilizing those N95s. You could, there is that one study from Stanford that showed that you can bake it at like 150 degrees, 170 degrees for 30 minutes, and that sterilizes it. So that's one way we're working on that.
You're up, Wade, so.
Okay, I'm up. I'll do my best. If I get disconnected, I'll get on the phone. I can see that?
Yeah.
Okay, great. So we're opening up here. We're one of the first states to start doing elective surgery. And just some background, Arkansas has a population of about 3 million.
You lost your audio.
Can you hear me now?
Can you hear me now?
Yeah.
Okay.
Okay, I'm gonna double it up here.
So,
Arkansas
has a population
of about 3 million.
Wade,
And
your computer.
Wait, you're using two microphones, so they're echoing.
Mute one of them.
Use your computer and use your phone.
got it. Okay, my computer's muted.
Good.
Okay, great. Here we go. Okay. So we have a population of about 3 million. We're a rural state. Some patients live 2 to 3 hours away. And we are a state that was never ordered to self-shelter. So we're a little bit ahead of things and a little ambitious. We've had 3,281 confirmed cases, 1,339 recovered, 61 deaths, and we peaked at April 21st with new cases. So it was announced that we could start performing elective surgery starting May 4th. And along with that came a lot of questions. If you look here at number 1, only outpatients with no plans for overnight stay are allowed. an ASA score of 1 to 2, no contact with COVID-19 patients, start with a small initial amount of cases, and PPP is issued. And then the big one, number 7, was you have to have a test ordered and the results back within 48 hours. So immediate questions came up. Which patients want to have elective surgery now? Where do patients get tested? What if there's not a 48-hour turnaround? What if the patient lives 3 hours away? And then, we don't have many ASA 1 and 2 patients. If you look at ASA 1, it's healthy, no smoking. If you look at ASA 2, it's minimal controlled comorbidities. If anybody has a stent or COPD or any of that stuff, they're level 3. So we thought, I looked through my sheet of patients. I didn't have anybody to operate on. But questions were answered. The hospital set up testing through admissions. For patients hours away, the hospital will test the day of, and it might delay the surgery a little bit. After people started talking about the ASA being a problem to do surgery, the hospital got interested, and they adopted the MENTS, which we've touched on. And your score must be 60 or less. And actually, that qualifies a lot of patients. I've got people who are 93 with a stent that have a MENTS score of less than 60. So we start here, First, we have to determine if it's urgent or not urgent. If it's urgent, you don't have to perform any testing at all. And then we sort of talk about those guidelines. Here's the MENTS. You have things like OR time, length of surgery, sort of environmental questions. Then you have disease questions related to, if a non-operative option is better. And then you get down here to the patient with their severity of disease for these diseases. And again, if you have a score less than 60, our hospital will consider that elective and do it. Also, just today, they decided that any skin cancer reconstructions are elective. So not just your really gnarly squamous cells or melanomas, but the powers that be said, basal cells and that sort of thing are elective. I don't know if that's a good idea. That's just the rule. So what we've done in our practice, we adopted the OMIC COVID-19 informed consent because I figure, 8 weeks from now, you'll start seeing the commercials. Have you or a loved one been, did y'all contract COVID-19 because you had an elective procedure? Please call Schlabotnik, and Jones. That's what you're probably going to see. So we have that consent. You can get that at OMIC. And then we have an order for the test. That's necessary. As I mentioned, we had to fill this out. And then you have to get the patient straight on getting tested. So the positives we're operating. The negatives are that there are risks to patients, the surgeon, the OR team, the office staff. This takes a lot more resources to schedule surgery. We started doing this yesterday, and I just held my nose and jumped in. We're getting it streamlined more and more, but the fact remains that we're much less efficient than we were pre-COVID, for sure. And that's it. I asked my staff what were some of the biggest problems, and they basically said efficiency to get these scheduled, and then also just the time and coordination with the patients. Many people are older, they need their children to help, so it's important to have contact numbers for their children to have them help. Basically, you just have to, what we did is we kept a stack of charts and we categorized them. Wanted to schedule but never was able to schedule. They were scheduled but then we had to cancel, and so on and so on. And then once you call them out and who's interested in surgery, then then you go through all of these different ways to get them qualified. But that's the gist of it. I can't see anybody, but I'll take any questions if you can hear me.
Are you able to stop your screen share for Sean Bladen?
Yes, I can do that. It should be out.
Thanks, that was really helpful.
All right, Sean?
While Sean's getting ready, can I say one more thing? You know,
Sure.
I wasn't sure how I could help people, but the one thing I would tell everybody is it's a little bit jarring to just suddenly start doing this, and it's sort of complicated. Basically, my staff recommended, letting everybody know that it's, it takes a little time to get in there. And, I can't speak to what kind of things you'll have to do in your state, but I'm sure it will be something along these lines. It will be a little harder than you expect. And I just encourage you to be positive and get going and just realize it's going to be a little bit harder than you imagine.
And I think most patients understand, so they, at least here, they've been pretty understanding about multiple reschedulings and putting them off. And we're just about at the peak now. And we had a little bump up even a couple of days ago. So we were supposed to start surgery week after next. They bumped that off another week because we had a little bit of not quite a surge, but we went up about 15% in hospitalization. So that's coming down. So hopefully that was just a little aberration. But it's going to vary.
I don't want to hold Sean up, but I'll give you an example of what hopefully you can expect. We called 26 patients today. 19 were ready to move forward. So those are pretty good numbers that they'll take you up on it, at least in Arkansas.
Okay, can everybody hear me?
Yes.
Okay. Can you see my presentation? I can't tell.
Yeah.
Okay. So we closed on March 20th. That was our last day. And so it's been about 6 weeks, as some of you already found out. Governor Abbott has lifted the ban on elective surgeries here in Texas. They sort of started that a week ago, but you had to have some attestation, and we decided to wait and see how other people were doing before we jumped in both feet. We do have our practice, and there are five doctors, 3 partners, and 2 employees, and then we have 2 fellows. But we also have a medical spa separate, and we have our own surgery center where we do the majority of our surgery. So I'm going to talk about each of those. So we stopped, our last surgery day was March 20th. We've had, I'm guessing we've done maybe 10 cases at most since then. And those were all urgent cases. We sort of grouped them into Wednesdays. I think maybe we've had a couple of Wednesdays where we've done surgery, but basically we've not done anything in our surgery center. We are already, ophthalmology practices sort of started practice last week because, as I said, they were able to see patients in their clinic. We decided to wait until this Monday to get everything set. So we plan to open up our practice in phases. We're going to open our office on Monday. We are lucky in that we have 3 locations. We have our main office in the middle of Austin, which is, pretty big. We have 2 sides where patients divide off into the right or left, depending on which doctor they're going to see. We have our medical spa where we can see patients, and then we have 2 separate small offices. So we're going to try and divide up our 5 providers. So there's only 1 provider in 1 area. So there'll be 2 in the main office, 1 on each side. So there'll be a front desk person on each side. we'll use the medical spa to see patients at least in the near term, and then we'll have one doctor at each of the other practices so that we can, you know, decompress, not have each other's patients crossing each other. As far as our surgery center goes, we're going to wait until May 11th before we start doing surgeries. Those will be, we're going to start with locals only. We have 2 ORs in our surgery center, one where we have an anesthesiologist that comes and does our anesthesia for us, and then the other side that we do locals, and we do a lot of locals. Our locals are generally not done with oxygen, so we usually drape the patient, you know, below the neck and keep their face open. Patients prefer that, but I think, at least personally, I'm going to start draping over the nose. There won't be oxygen built up under there, and I will feel safer doing it that way. And then the medical spa, we're not sure when we're going to open that. I suspect we're going to start thinking about doing that maybe in 2 weeks and see how that goes. And I'll talk about that in a little bit here. So as I said, there'll only be one physician on each area. We're going to space the patients out, not really an hour, but it'll be every 30 minutes. And we'll see how that goes, unless the surgeon says, I need to spend more time with this particular patient, and then we'll expand that. The patients we're only going to allow the patients to come into the office unless they're a minor or an elderly person that needs to have somebody come in. Otherwise, we're going to have family members stay outside the office in the car or whatever. They will be required, they'll be told before, you know, when they're making their appointment, that they need to wear a cloth mask or something over their face, which shouldn't be too much of a problem at least in our area, because over the last 3 weeks, everybody's been mandated to wear masks outside. And as far as I can tell, everybody's sort of wearing them. If they arrive without one, we will then provide them with a mask. And they'll have to wear it the whole time they're here. We are screening. I mean, it's the best that we have as far as appointments go. They'll be asked, you know, all about COVID-related symptoms, and we are going to use a thermometer. It is a contact thermometer, so we're going to have to sterilize it in between and go from there. We're going to do the same thing for our surgery patients. We also plan to do the same thing for staff. Every day, we're going to be asking the staff and actually asking them, because some of them do want to return to work. We don't want them staying there if they're ill. And we're going to be measuring each other's temperatures to make sure that we're all safe as well. And all staff will have to wear a mask. Now, obviously, what type of mask depends on what they're doing. Our administrative staff can wear their cloth masks if they've been wearing at home. If they're techs and more direct patient care, we're going to have to get N95 masks. As it turned out, a statement came out of the Texas Medical Board, as Mark Mazo was mentioning, which pretty much echoes what we're doing. So, and this didn't seem like guidelines. This seemed more like a mandate. So the TMB is requiring these steps. They're not saying this is best practice. They're mandating these steps. And in fact, they're also requiring that all of these steps be placed on a statement and placed in the waiting rooms for patients to view. So, so these are things that all officers should be doing at this point. As far as our surgery goes, we own our own surgery center, which is where we do the majority of our surgery. And obviously, we're having to look to other surgery centers and the hospital for best practices. Basically, the same instructions for patients coming into surgery will be the same as in the office. They'll be required to arrive in a mask, which will stay on until we need to have them take it off for surgery. And in some cases, we may, I mean, I've been doing this for procedures where I've had to do some biopsies, and I've had the patient just leave their mask on for the whole procedure. As far as testing goes, it is true that it's not mandated, it's recommended. Obviously, all our hospitals are, you know, up until recently, they've been actually having the patient be tested twice. Now it's just once. We just did a case at Seton this morning, and they required a test for her, and she was beyond, because the hospital changed her date, she had to get tested again. So we've heard that some of the other big owners of like HCA and USPI they're not actually necessarily mandating testing because it was causing some inefficiencies, and surgeons were asking not to have all their patients tested, because if the patient didn't get their test or they didn't get the results back, their cases were canceled. We are planning on testing everybody, at least at the start. We want them to get tested 5 to 7 days. It would be great if they got tested 24 hours before, but we understand that we'll have cases canceled that way. So we're planning on testing them 5 to 7 and then asking to self-isolate and keeping our fingers crossed, I guess, that they will self-isolate. In the state of Texas, and I think this is the same for most places, patients' insurance will pay for these tests if they're being done for surgery. We're lucky in Austin that there are multiple places. We've been very lucky that our nurse director of our surgery center has been spending a lot of time while we've been out looking at anticipating some of these things. And there are multiple testing sites that we can use, both through University of Texas, Ascension Seton, some other private, and to get PCR tests and reliably 5 to 7 days out. And it turns out one of our biggest issues is that we see patients all over Central Texas. I go to Midland, although I'm not planning on going there soon, but I go to Midland, Waco, Bryan College Station. We cover a big swath of Central Texas. And we were concerned about whether those patients would have access to testing. It turns out that there are places that they can test out there. So we are planning on testing at least in the near future. Let's see. As far as our OR goes, obviously we don't have PAPRs in our surgery center, but we are going to require everybody in the OR to wear N95 masks for every case. There is a lack of N95, as we all know. So one of the things that Travis County Medical Society and other people have recommended is, rather than have the same mask and wear it every day and throw it, for a week, we're rotating them. So you have paper bags. You have to have something breathable, but you take off your N95 at the end of the day, you stick it in your paper bag, and you can use that mask again in about 72 hours, and the virus should be taken care of during that time, and you just rotate through them. So each person will be given 4 masks, and they just get rotated through. So they wear the mask that was placed in the bag 72 hours before the next day, until we get adequate PPO where we don't need to do that. We are, at least for now, planning on just seeing how things go with our local cases. We have 2 rooms, but we're only going to schedule 1 surgeon for the whole of the surgery center at a time, and have adequate time to go from case to case. And we're going to see how that works and how many cases that we can do. We'll start off slow. We're not even sure how many patients. We've obviously been keeping track of all those patients that got canceled during this time that we're out, and then the few that we saw during telehealth. We're not sure how many of those actually want to proceed with surgery right now, as somebody else stated. But we're going to work through those and see, start off slow and see our efficiency and go from there. We're lucky in that our patients don't leave the same way they come in. So our patients come in the front desk, they get signed in, they go do their surgery, and then they get taken to their car through the back door. So there's they don't cross over from each other. As far as going to local max, probably what our anesthesiologist actually works for the big group that covers Seton Medical Center. And so I suspect that we're going to have to follow the recommendations and policy that they have at the hospital, one of which is trying to avoid local max and just doing intubations, because that's safer for them rather than local max, where you're constantly dealing with an open airway. Not just the anesthesiologist, by the way, but also you as a surgeon, you're constantly dealing with an airway that's open and breathing out, whereas when they're intubated, it's more of a closed system. And probably will follow the same recommendations that they're doing in the hospital, where everybody is out of the room except for the people that need to be in there for the intubation, and then you wait 10 minutes and then start the case. But we're not going to go to anesthesia patients until, general anesthesia patients until we see how the locals go. I'm not sure what we're going to do. We've had a long discussion between the partners about whether to proceed with surgery such as DCRs. We do DCRs in our surgery center, whether it's those will be safer under more control systems at situations in the hospital. We're not sure how we're going to do that. I was lucky enough to get my daughter's, I don't know if you can see this. Yeah, I guess you can. So my kids' high school, they have a very active robotics team who did a lot of 3D printing, and they were able to take a design off the web that fits over your head. Initially, they came up with these little sleeves that you get for a file, and they made the button so that you can stick them on like this, but this is too opaque. So they actually went to the trouble of ordering a bunch of acrylic sheets and cutting them and then punching holes in them so that I can have a sheet all the way across the face, and you can turn it this way or this way, and you can actually wear loops underneath. As far as the headlight goes, I'm not sure. But our biggest issue is making sure we have enough PPE, especially the N95 masks to cover everybody in the OR. I think I'll stop there. I don't know if you guys are interested, but I thought I would show this. One of our fellows, Dr. Homer, she'll be presenting this later. And I thought that was interesting. She did a survey among ASOPR's members, and she looking at different questions about during this time that they were off, how many people laid off their staff, how many furloughed, how many continue to pay their staff. And I thought this was interesting, a big spread. Most people ended up furloughing their staff, which is what we did. We have about 50 plus employees because we're a big practice. And that was the biggest burden for us, is that we didn't want to lay off anybody, because when we restart, if all of those people go on unemployment benefits, they may not want to come back, as already stated. So we want to be able to start with our feet on the ground. So we needed to keep our employees furloughed, and hopefully we'll get the PPD, the PPP. We haven't got it yet, but also, again, this is a little breakdown on who applied for it, not necessarily who people who got, but who applied for the PPP. And you can see a significant amount of practices did. Successfully received funding. This has been a major frustration for us, because we used Bank of America, and that still hasn't come through, although our application's still in. But you can see there, again, there's a big range about who has actually successfully gotten it already. And I thought this was interesting. Obviously, we're all stressed out, as we have been. Again, it's interesting that there are some people who, I think that the people who are mostly concerned are the people like us who have a private practice, and maybe less so if you are on staff at a academic university. Anyway, so that's what I have. I'm more than welcome to answer questions, although I will say I learned more than I'm teaching during this. So.
Sean,
Say that was great.
Can I have a?
Go ahead, Sandy.
Oh, sorry, you mentioned that your anesthesiologist prefers to do everything by intubation. Does that mean you're doing that for your blephs and very quick?
No. So in our practice, we do a lot of local cases. We do almost all our blephs, ptosis, ectropion is done under straight local. So, I mean, they get a Xanax, and we monitor them and all that stuff, but they're away. So we don't intubate those. We don't do those under local MAC. So we're able to get a lot of those cases done pretty quickly. Our other room where we do anesthesia would be more for if it's a quad bleph, if it's a DCR, orbital decompression, our bigger cosmetic, facelift cases and that kind of stuff. We have to do that we've done that under local MAC. Obviously, at quad bleph, it's a lot easier to do under local MAC than general, but generals are safer for the anesthesiologist too. So.
I think it was terrific. I think we answered some questions along the chat feature as well. But thanks, Sandy, for corralling this, and Sean and Wade and Ollie and Scott. hope you found it helpful. Like I said, we're going to have to figure this out as we go. You got to take it slow. And I think that, around here, everybody's kind of taking the attitude where we're going to do things for a couple weeks at a time. And that seems to be the interval, for quarantine and so forth. So every couple of weeks, if things are going okay, they go a little more, and then in a couple of weeks, they go a little bit more. I think the limitation is going to be patients are going to be afraid to come in, and I think one of the best things you can do is just show your patients that you take their safety seriously, and we're sending out letters to all our patients that, everybody's being screened, everybody's wearing a mask. We clean the office several times a day. We clean every exam room after every patient, all the surfaces, including the computers and the slit lamps and everything with the PDI wipes and so forth. And just to let them know that it is a safe place. And I think that's going to make a big difference. But everybody, patients and staff and physicians and everybody, this is all new. So I appreciate everybody's input and wisdom, and hope the discussion continues on the forum. But if there's any other questions, folks, I'm sure will be happy to stick around. But it's Friday, and at least in Rhode Island, it's about 60 degrees and the sun's out, which hasn't been that way for about 3 weeks. So I'm sure that you get better things to do on a Friday afternoon.
Yeah, thanks. We'll try to summarize some of the talking points, but do you guys think it's worth kind of rediscussing after a couple weeks, 2-3 weeks, to see what new issues arise to kind of help each other out with our experiences? Maybe we could do it again in a couple weeks. I think it's been really helpful.
Yeah, I think that would be a great idea. Especially parts of the country that will have garnered some experience will be able to teach the rest of us.
Yeah, I would agree. I mean, I think your experience is always your best teacher, and as things start to open up, and it's going to open up at different times in different parts of the country, you're going to learn, from your, I don't want to say mistakes, but from your experience of, how'd you get your testing done? Where are you getting your PPE from? What did work? What didn't work? What kind of cases are you doing? What aren't you doing? So I would, 2 to 3 weeks from now, I think would probably be very helpful. Right after Memorial Day.
I have a remarkable internet connection now, if anybody wants me to do that again.
Oh, thank you, everyone. This was really helpful. All right.
High school must be out.
Okay, I'll record. I recorded half this session, so I'll try to post that. And then it was my part in Mike's intro that I didn't record, so I might try to re-record that if people who are interested. And then we'll try to post it in a day or so.
Great.
Very good.
Right.
All right, thanks,
Great.
everybody.
Thank you.
Great seeing everybody.
Bye.
Thanks, everybody.
Thank you.
Good weekend.
We'll see you.